It's my great pleasure to introduce Professor Brian Draper to the stage to now talk to you about alcohol and drugs and the ageing brain. So as I said, that we want to now drill into some of the very specific and important issues that will help us get a better understanding of what's happening with older people and the use of various substances. Please make Brian Draper very welcome. Thank you so much indeed. Yes, you need to take this.
Thank you. Thank you, Anne. What I'll try to do is negotiate this. Yeah. Okay, we've got a different set of pictures, but they're sort of still representative of the broad range of ageing. But these people are either relatively famous or unfamous for using their substances from a very early age, most of them. And some of you might recognise, some of you may not. But I think it introduces this general issue that Anne mentioned, is that what is old? We're talking about a very broad range of age, because really in the drug and alcohol sector, anything over about 50 is old, and we've heard about in the Aboriginal people, old starts at a fairly young age too, 45 traditionally in terms of the way Commonwealth looks at it. So we're talking about a very broad range of ages, which might work well in terms of biological age, but doesn't work too well in terms of social aspects of ageing. 50-year-olds, 45-year-olds don't think themselves as old, even if they physically look old. And so they don't necessarily relate to the 90-year-old that we also call old. So we've got to think here, we're talking about a very long age range with a lot of different issues, and they'll present in different ways to different sectors in terms of the health sector, in terms of social interactions, and some of that is indicated on that slide, and different drugs that they might have. So there are a number of what we call geriatric giants which interface with this, and in terms of how the ageing brain and the ageing body might deal with it. I'm not going to go into some of these in any great detail, but just to point out that immobility, frailty is a huge issue. Intellectual impairment, I'm going to talk about this a little bit more, but dementia it occurs in about 9% of people aged 65 and over. So that we're talking about a great interaction that we have to be aware of, and a big issue. In fact, one of the probably the major issue of ageing in most respects. Instability, risk of falling, and of course in the drug and alcohol population this is well known anyway across the age range. Incontinence, huge issue in terms of older people, and a bit later we're going to hear talks about polypharmacy and what we do to older people. We've already heard issues related to that with some of the prescribed misuse of drugs. Well, part of that comes down to, in part, to polypharmacy as well. So in our efforts in life to keep people going with chronic ailments, we're giving them more and more drugs, and of course we're creating more and more problems in doing that. Incidence of dementia increases exponentially with age, basically. I think to us in the aged care sector, I'm saying something that's just sort of so what. But maybe in the drug and alcohol sector, it's not as well understood how the increase of dementia increases so rapidly. And so by the time you reach your 80s, 85, you're talking about 25% of the population has dementia. And of course, this has a huge impact on how we organise services, how we provide assessments and so forth. And so we always have to bear that in mind. That when we start talking about the intersection of drug and alcohol issues with this, we're really talking about incredible comorbidities that create enormous complexity. And people, as they get older, respond to drugs differently. We can't use the way that we use drugs in 40 and 50-year-olds or 30-year-olds and expect 80 and 90-year-olds to respond to those drugs the same way. The simple fact is they don't. Drugs take longer to excrete, to metabolise, so one dose of a drug just lasts longer. And we frequently see people admitted to hospital after taking a few extra drugs, doses of a drug, and be sick for days on end. The effects of drugs can be drastically different, often related to comorbidities, often related to the other drugs that they're being prescribed. So the whole world starts changing in terms of how we understand things. And one of the big banes of people like myself and others in the audience here who work in the aged care area is how too little research is done on, say, new drugs that actually looks at what happens in old people where most of the drugs are prescribed. And it's quite frightening at times, the sort of research that allows drugs to be used. The effects of things can be synergistic, and in this field, 2 + 2 doesn't equal 4. It often equals 5 or more. And so it becomes very complicated. We go from the worldview of medicine, one cause, one effect, to multiple causes, multiple effects. And so a lot of the work we're doing is largely about nibbling away at the things we can nibble at, reducing the risks attached to it. That's not just biological risks, it also includes the psychological and social and environmental risks, because it's quite broad. Alcohol, just turning to that to start with, there are obviously, from what I've just said, physiological change is impact upon how the body metabolises alcohol. So there's a bigger bang for your buck. A lot less does a lot more. And in fact, generally speaking, you talk to people who've been drinking for most of their life on a regular basis, most people will tell you, well, I've cut down what I used to drink. And they can't actually identify a specific reason other than they're getting the same benefit, if you like, from smaller amounts than they used to get from bigger amounts. That's the gist of it. There are very few guidelines out there, certainly none that are evidence-based, really, as to how much is reasonable to drink. We simply don't know. The UK guidelines are lower than the Australian guidelines, but whether that's an accurate or a correct way of looking at the world, I simply don't know. The other thing that we've heard a little bit from Anne, but I think it's important to understand in the drug and alcohol sector, sure, we use drugs to get pleasure, but they're also, beyond the pleasure principle, there's also the benefits, health benefits that might accrue from using some drugs. So alcohol is a great case in point. If you really look at the data, that most of the data that's put out there for what alcohol might do to cognition in late life, it suggests that it's protective against dementia if used in modest amounts. Modest amounts is hard to define precisely what that means. 1 to 2 drinks a day, sort of. There's dilemmas with that data in that some of the data is from populations which might exclude those who are really drinking excessively. But having said that, this is the data about that a lot of our work is in terms of public education is often based on. So if you went to Alzheimer's Australia website, they would talk about the possible benefits of alcohol. They don't recommend people drink alcohol to prevent dementia, but they mention. So we have this area here where we have a substance that we know causes harm, but we also are suggesting it might cause benefit, and the amounts that we're saying where the benefits and the harms begin and end is completely unclear. And also, it could be, some might argue, well, maybe some of that data upon the benefits might be not correct, but having said that, it's a lot of studies that have suggested it. It's not just one study, and it's not just the brain, it's also cardiac. So it's a bit, it's one of those areas we need to be aware of. And the long-term risk of drinking, I guess in terms of the harm side of the equation, over a lifetime, that only starts reducing when people reach about the age of 70. So in terms of harmful use, we see continued use at a harmful level in the 50 to 70-year-olds, even pre-baby boomers. So we've got a kind of a contradictory set of issues here that I think, from our perspective in this audience, creates problems of what do we communicate? What are we going to tell people out there about what they should and shouldn't do? And I think that's probably the one of the more critical areas for us to get some quality research about. Issues of comorbidity, as I've already indicated, are increasing with age. And alcohol use comorbidity, of course, alcohol we know causes a whole range of ill effects, both physical and psychological, and I've got them listed there. I won't go into any of those in any great detail, but clearly that's one set of issues. We looked at it in a slightly different way in a study that came out a few months ago, where we looked at people in hospital, in aged care wards, people who have been treated in the community sector by community aged care, old age mental health teams. And we excluded people with dementia because we needed to get some accurate information, and people who were acutely confused from whatever cause. And which exclude, as you can see, 55% of the potential sample. That gives you a sense of what's actually in the hospitals. So a large proportion of the older population in the hospital is confused for whatever reason. So we excluded those. And we got a high proportion of the people who were otherwise there agree to participate. Now, the key message from this slide, well, alcohol was the main drug of misuse that we identified. Prescribed overuse of prescribed drugs was the second most common problem. No illicit drugs. But when we looked at those who were identified as having a substance misuse problem versus those who didn't, on a population of people who are already in aged care services being treated for their multiple medical comorbidities, we could not identify, couldn't distinguish the people who are misusing drugs and alcohol from those who weren't. This raises an important issue. This population is not going to be easily identified through comorbidities because the comorbidities are already there in that population. This population already has all these comorbidities. You're only really going to know if a person is misusing alcohol or other substances by asking, by actually getting that information. You're not going to get it through their clinical presentation per se. Alcohol, depression, suicide is a big issue, of course, across the age range. Biggest issue in middle-aged people, but it's still an important issue in late life. So a study that we did a few years ago, psychological autopsy study of looking at suicide in people aged 35 and over. And as you can see, in the people who age 60 plus, over 14% of the 60 pluses had alcohol use disorders as part of their suicide, as an issue that was identified. Much higher in the middle-aged group. But suicide and depression remains a very important comorbidity or effect, if you like, of substance misuse in this population. Late onset disorders, the reactors, as Anne described them as, about a third commenced in late life, and as there are a whole range of different issues here that this population provides. They're often relating to issues that are going on in life, and one big area that I want to draw attention to is that we're seeing, and we really don't have a good handle on, is the increasing use of alcohol in people with early stage dementia. And this is a very difficult population. Most importantly is that the person who's drinking too much doesn't even know they're drinking too much because they forget that they've only had that one drink 5 times already. And they'll tell their son or daughter, yes, I've just had one drink today, but of course it's the 5th time they've had that one drink. So this is actually a huge problem. It actually has an enormous difficulties in identification and management. We're struggling as to how best to deal with the issue. And it's an area that we're currently doing a bit of research in, and both at a clinical level and at a more sort of academic level, if you like. The one angle that's important here is that it's not just an issue of causing problems related to community management. One of the studies that we did looking at hospital admissions in New South Wales, basically people with dementia, not due to the alcohol, but with dementia of any cause, had a 5 times increased rate of alcohol use disorders in their hospital admissions. So it's what it leads to is hospital admissions. It leads to health interventions required. So it's not just, oh, they're drinking too much, they're getting confused at home. They're ending up in hospital, many of them. And so this is often not well recognised and understood as being an element of it. In terms of cognitive disorders and alcohol, we need to be generally aware. We're not just talking about alcohol-related causes of dementia, but there's a whole range of other cognitive disorders too. So you've got the acute intoxication effect, which, as anybody who knows who talks to an intoxicated person, they're not quite there cognitively, not quite accurate in their understanding of things. Then we have withdrawal effects, which again has effects on cognition. We have, particularly importantly in the alcohol population, the Wernicke's, acute Wernicke's syndrome, which due to thiamine deficiency, which is a medical emergency. If we don't give thiamine parenterally to this population as quickly as we can end up with permanent effects of alcohol-related brain damage or a Korsakoff syndrome. So these are medical emergencies that are to varying extents recognised in emergency departments. How much is happening at a lesser severe level within the older population who drinks as much, we don't really know. There's not been any good studies that have really looked at that. Certainly when you get into the very old, 75, 80 plus, it's probably not a big issue, but I'm more concerned about people in the 50 to 75 year age range where there probably is maybe more of it going on there than we realise. So Wernicke's Korsakoff, I've just mentioned. Acute syndrome is Wernicke's encephalopathy, and one of the things is that Wernicke's encephalopathy traditionally had a triad of symptoms, which were basically cognitive changes, ocular motor changes, and gait changes. Well, if you use that traditional triad to make the diagnosis, you're missing a lot of cases. And so more recent research has shown that you really need 2 out of the 4 there to make the diagnosis. And if you do that, you get fairly close to probably what's happening in the population. So, as I said, only 20% of Wernicke's patients are identified before they die, which is a frightening thing for a completely reversible problem. And a lot of people get severe permanent impairment. There are several terminologies used to describe the long-term effects of alcohol causing cognitive changes. Alcohol-related dementia, the Wernicke's Korsakoff syndrome, but often the terminology, particularly coming from the UK, is the term alcohol-related brain damage, which basically is an amalgam of both, recognising that there's a heterogeneity of presentations, that in fact in both types of disorders you've got overlap, you've got a bit of the thiamine deficiency and alcohol-related damage, you've got a bit of alcohol neurotoxicity occurring in some of the Wernicke Korsakoff patients. So that's been the direction where the research and the way of looking at the world has gone. There's other reasons for looking at it that way. One is that the term dementia is stigmatising for younger people with substance use problems. And so that has, in fact, the alcohol field and the HIV field have been the 2 fields that have led to, in DSM-5, which came out last year, the term dementia no longer appears and the term is replaced by major neurocognitive disorder. And the fields that actually mainly contributed to that change in the United States were the alcohol field, traumatic brain injury field and HIV field, because these were largely younger populations who felt that the term dementia related to old age and not to them and was stigmatising them. So that kind of influenced that. And so these days, alcohol-related brain damage is increasingly the term that seems to be used. And to draw your attention though, it is still something that happens in younger age groups, 40 to 70. There isn't strong evidence that we see many cases directly due to alcohol over the age of 70. There probably are some, but not many. Really the peak of occurrence is in that young old age group, if you like. And because in the old, it tends to be mainly the traditional vascular and Alzheimer's conditions, and it's usually a comorbidity with those conditions. I've been running a young onset dementia study, and this is not from that study, this is from a hospital study, but we did a similar study in our young onset, but to point out that, here we are, so this is breaking down dementia admissions by age group, and you can see that's alcohol related, and you can see that they basically dominate the 50 to 65-year-olds, but they're barely seen after that. And that's really the reality. The action is occurring in that peak 50 to 70 age group. And so in a way, when we're thinking about the future and older populations, it's more going to be the alcohol comorbidity with a primary dementia that's going to be our issue than any great change in this population. There may be some change, but that's not where the problem, I think, is going to largely lay. One of the problems, and Stephen Bright will talk more about this a bit later, I think, is identifying cognitive disorders in older people. No, you're going to talk about screening more of that, yeah. Okay. Traditional instruments that we use in aged care, mini mental state examination, for example, RUDAS, for example, these are not necessarily the best instruments in an alcohol population for screening. So the Montreal cognitive assessment is probably the MMSE equivalent in the drug and alcohol field because it picks up frontal disorders much better than the MMSE. And it's about the same length of time to do, which is acceptable. We would use a longer instrument, which is not suitable for screening. The instrument that I tend to use is the Addenbrooke's cognitive exam, which also is very good for frontal, but takes twice as long. So it's not a good screening exam, it's a more detailed exam. Yeah, so anyway, so there's a lot of challenges with alcohol-related cognitive disorders. We need collateral information, there's high rates of comorbidities, there's problems of long-term care. There are very few residential facilities that are keen to take such people in because they often have frontal disorders, behavioural changes, aggressive disorders. Frequently we're talking about a higher male population in their 60s that don't fit in well with the 80s and 90-year-olds. Long-term outcomes, though, we've got to be aware, a lot of people do very well. So there isn't very much good data on this. You can see this is a very old study, and it's not a great study, but there really isn't much better data. We certainly need better data about the long-term outcomes of people with alcohol-related cognitive disorders. I won't go into this in great detail, just to talk about issues, because we've heard about the numbers, but the benzodiazepines basically should be avoided in older adults. They cause more problems than they help. They're mainly prescribed to treat sleep or anxiety disorders, and there are better ways of dealing with that. More often than not, the sleep disorders are people worrying about a normal sleep pattern that's changed, and the anxiety and stress disorders can either be best dealt with non-drug treatments or treating a depression, which is usually the primary cause of the disorder. So just to say that there's not many indications for the long-term use of benzodiazepines that I'm aware of. But there are lots of problems, and certainly problems related to cognition. Benzodiazepine use increases mild cognitive impairment, and there is a debate currently which is unresolved as to whether they might even increase the risk of developing dementia down the track. The evidence for that is not strong, but there's certainly evidence mounting that there's something going on. Most of us, I think, in the field feel that we're talking about what happens in people in their slow evolution into a dementia is that anxiety is one of the early symptoms that happens even before there's any marked cognitive change. And what is ending up happening is that they're being treated for their anxiety, which is part of the prodrome of the dementia. Not that anybody is aware of it at the time, but so we're seeing really a comorbidity effect. But we do know people who actually take the drugs have worse cognition, but I think it's debatable whether they actually cause dementia. We've heard about opioids, how the increased use in chronic pain is a big issue in this population. And in terms of cognition, I think it's important to be aware. One of the concerns that's been raised has been that perhaps the opioid substitution therapy might affect cognition. There was one study done in Australia by Shane Dark and his colleagues a few years ago, but looking at people in their mid-30s, and they compared the Suboxone with methadone, couldn't find any cognitive differences, but they did find that the people in this age group were already showing some cognitive deficits. Now, we've looked at this a little bit, just another slide about how a lot of this population has problems of depression and then pain. So pain and depression in this older VA population in the States were important comorbidities. We've looked at this in a study that's currently in press in South East Sydney. Nick Linzeris led the project, where we looked at 99 people going to age 50 and over going to drug and alcohol clinics in our district. 70% were on opioid dependence, and 70% of those were on methadone, 30% Suboxone, and the rest were alcohol primary. I think one thing to say is that polysubstance misuse was the rule rather than the exception. We looked at their cognition, and interestingly, when you get to this group, so we're talking now people in their mid-50s on average, there is a difference. People on Suboxone are doing better cognitively than those on methadone by a significant amount. So there may be something here that informs the field as if we are going to see more and more people requiring opioid substitution therapy in later life. Maybe we've got to look at what substitute we use, because it might be that once you get older, methadone might not be the best one from a cognitive perspective. Mood is also, in our study, was also a big issue as well. And we used the Addenbrooke. So just to point out a number of points here, just 40% of this population were functioning in a dementia range on the Addenbrooke's cognitive exam. Not they didn't have dementia, because many of them were intoxicated, of course. We only get a sense of permanent impairment a bit later. But it illustrates the population we're working with are operating at a cognitively impaired dementia level, 40% of them. So that implies how we have to do our service delivery. And I'll step over that. Cannabis, as we heard, is increasing now. There's not much data on long-term effects of cannabis into old age. I mean, this is from Wayne Hall's article of last year, where he summarised the 20-year effects, and you can see nothing much is very good. We don't really know what will happen health-wise and cognitive-wise to people the baby boomers who have been using cannabis regularly for 25, 30 years. It's a watch this space. There is no evidence, there's no data of any great consequence. There are a few warning signs in some of the data to cause concern, but there really is no data. But health-wise, you can see in many areas they're doing terribly. And this is the concern. We just don't know. I won't dwell on that particular slide. But I think the cognitive effects needs to be looked into more closely. One study from the States, epidemiological from the ECA studies, didn't seem to suggest an effect, but there were weaknesses in how they did that study. They were using the mini-mental state exam. Again, maybe not the right instrument to look at that question. Cocaine, not much happening now, but the reason that I'm raising it, besides liking the Hugh and John Entwistle, who died of cocaine misuse, cardiac effect, is that there are lots of health effects of cocaine. And if people are surviving into late life with regular cocaine use, they're going to have lots of multiple medical problems. And there's also concern about what it might be doing to the brain cognitively. So if people do survive in reasonable numbers with long-term cocaine use, we can expect to see a lot of major comorbidities mounting. I guess that's the question, will they survive? Well, some are. We certainly know that. Although they're not coming to our services just yet, I don't think. So just concluding, I think, to put it together, I think chronic substance misuse that survives into late life or early late life is really akin to premature ageing. Basically, that population has done to itself through its substance habits and associated lifestyles what most of the rest of us do through just natural living, but take about 20 years longer to do it. And so we're seeing a microcosm of ageing happening quicker. That implies, obviously, ways in which we can have to address the problem. I think we have to start using the principles that aged care services have, nibbling away at the various comorbidities as best we can, as well as obviously minimising use as best we can. And also, of course, it gives them, maybe we have to start to imply what DNA services need to start doing at a younger age that they're not doing now. Is the current DNA population service structure doing anything at all for people in their 30s and 40s to anticipate late life? I don't know, but I suspect the answer is none, nothing much at all, other than trying to get them off whatever they're taking. So that is a challenge I put back to the drug and alcohol sector. What are you doing with your younger people? Because they are the ones that you're going to have to start focusing on. Other than that, thank you very much.